everyone. Thank you all so much. We had almost 100 people register for this. So we're super excited. We know not everyone can make it. So this will be recorded and we've got a lot of content to cover. So I'm not going to waste too much time. I'm Bridget Wallace. I am co-owner of 360 Neurohealth and clinical director of 360 Neurohealth. I also have a private practice in Austin, Texas. I've had this one for 23 years now, specializing in dizziness and balance disorders. And for those of you on this that follow us, you know I love technology. I love vestibular diagnostics. I love anything that produces a report and monitors progress. And I've been following virtual reality for many, many years. And I was just fortunate enough to hook up with Patrick, who I'm going to introduce you to, of E3 Diagnostics. And, he knows I'm interested in virtual reality. And so I said, can you find a key thought leader out there who's implemented virtual reality in their practice? And so he's like, yeah, I know exactly who we can go to. So we're going to be fortunate to hear from Mike. And I love it because Mike, being in the private practice environment as a small business owner, I often listen to things from the bottom line. I want a lot of things, but can't have a lot of things. So I'm really anxious to hear what he has to say, and anxious to learn how we can best integrate this into our practice as well. So I love it that you've already introduced yourself. What's super grateful we're super grateful when you just tell us, what's your setting, what's your discipline, what's your setting. You can tell us where you're from. I actually see, I don't even know what time it is, but I see Dr. V on here, who also loves technology, and he's in Greece, so it's good to see his name on here. So just in chat, uh, type in what your background is, share where you're from. And what we're going to do, Mike's got a lot to cover, but it's also helpful when he sees what your discipline is. We can always kind of move in different directions. The other thing is we're going to have save some time at the end for Q&A. We did get a handful of questions before that we're likely not going to have time to cover, but we will continue to follow up with you and make sure those questions are answered. So we already have Mike. We've got a few PTs on here. We've got an OT on here. Thank you so much. Just keep putting that in chat, and then let's do one more question before I turn it over to Patrick. Put a 1 in the box if you are using virtual reality right now. Put a 1 in the chat box if you're using virtual reality right now, and you can put a 2 in chat if you really are interested in adding it to your practice. So I should put a 2 in the chat because I'm super interested in adding it to the clinic. So I'm going to turn the floor over to Patrick. Patrick, thank you so much. You've done a lot of work to make this happen. It does take a lot to plan these. We met at CSM, following up with this. So thank you for sponsoring this. E3 Diagnostics, we're announcing them as our newest industry partner. And that's good for our members because it offers you some discounts, which I'll tell you about that at the end. And really appreciate, Patrick, the work that you and Brian have put into have Mike be so gracious to do this. So I'm going to turn the floor over to you for a couple of minutes before we turn it over to Mike.
Yeah, thank you, Bridget. So I'm Patrick Allo. I'm the manager for PT for E3 Diagnostics. I had been in the physical therapy industry for about 10 years. One of the virtual reality products, we have a virtual reality product called Virtualis. And just to give you an idea and a background, because we're talking about vestibular rehab. So Virtualis is founded by a physical therapist in France. His name is Frank Assaban, and he started dabbling in virtual reality as a way to treat motion sickness, his motion sickness. He was an avid scuba diver, got seasickness, and started using virtual reality, and he cured his seasickness. And within his clinics, he said, "Hey, I want to start using this on my patients to treat motion sickness," and hadn't done it with some great success. So from there, he said, wait, I can start using virtual reality to treat continuum of care. And I can treat not only vestibular rehab, I can treat neuro patients, orthopedic, chronic pain. Then he formed a company out of France in 2015. And he started Virtualis in 2015. And from there, he had brought me over because I had a huge history from Natus Medical with the Neurocom product line, brought me over, and we started talking, and we started selling Virtualis and virtual reality in the US in 2019. So we currently are in 24 countries and expanding. So yeah, Virtualis has assessment and rehab modules that are all in virtual reality. And Mike's going to talk to you, and I'm going to turn it over to him right away because he's got, like Bridget said, has a ton of content, great content. There's a lot of it. And we want to make this all about you and your experience and what you want to learn out of virtual reality. So I'm going to turn it over to Mike. So Mike, go ahead, and it's your show.
Thanks, Patrick. I
Yeah.
just couldn't. I'm going to have every one of you just look at this, and I apologize because it's going to be a lot of information, but I wanted to give you a bird's eye view of the future and what is going to happen in your clinic if you had a particular piece of equipment like this. I'm in Tulsa, Oklahoma. I have had three clinics. I sold them. I'm a physical therapy and balance center franchisee. Did that in 2014 and sold it to them in 2023. I have found Virtualis to be one of the most effective uses of technology in my entire company. And we are now, because of the things that we've done, the education we've taken, the quality of our therapists, the premier leader in Tulsa, Oklahoma, as far as I'm concerned, of providing balance and vestibular therapy. We're going to talk about all the ability and all the things that are available. And so when we do that, we are going to move. But I just wanted you to know, why should you use it? Mostly because if you take a look at, this is a picture of Frank. He's moving his head and neck, so he's doing gaze stabilization. This type of technology is useful for lots and lots of vestibular issues, lots and lots of neurological issues. And really, one of you will find that we used it a lot for musculoskeletal issues. And so if we take a look at what we were seeing here, this is a gaze stabilization program that you are actively following the line of that planet, and you are the green circle is what you are using to follow it. If we look over here, this is what it looks like with the patient. And this is a very good friend of mine. He's been coming to the clinic for probably 4 years. He loved it so much. He had so much fun with it that he decided to buy an Optiplex head set, and he has his own computer. He doesn't have the software that we use, but he does have software that's able to be managed by him. So again, this gives us an opportunity to go out to the patient's home, do a visit, go ahead and set up his program at home so that he can continue to follow it while he comes back to the clinic. There are three key objectives that we're trying to give you tonight. One is to make sure that we can look at the advantages of virtual reality, but we want to be able to make them quantifiable. We then want to demonstrate evidence-based protocols that are using virtual reality-based treatments for vestibular disorders. And we're going to look at, how do you get this equipment into your clinic? How do you teach your therapists how to deal with it? What are some of the clinical workflows that you can use in your clinic? So objective one is to identify specific clinical applications where VR assessments provide quantifiable advantages. So in this VR software, what we can do is we can take a look at increasing the speed of head movement, increasing the amount of motion in the spine, arms, lower extremities. We can have them turning up to a 360-degree circle, and we can do it and measure it so that we can go back to the next treatment and be able to quantify exactly how far they went, how good they did it, at what speed did they do it, as opposed to having somebody in the gym being able to mirror what you're teaching them to do, but at the same time, it's not as standardized basically as it could be. I believe that it provides distinct advantages over traditional methods because of the precision, standardization, and ecological validity. One of the things, ecological validity, by the way, is just the fact that you can put this into the real world. And so your patients can be immersed in something that you can't do that in the gym. If we take a look at these two pictures again, you can see that what you can do is maybe measure the squat, the range of motion of the patient, the fact that she's balancing, or the fact that she can move her upper arms, lower legs, whatever. But in the virtual reality, the platform that that patient is standing on is measuring their sway, it's measuring their foot placement, it's measuring the speed at which they're moving. And what you could do if they're very seriously involved is you could slow it down so that in the case of a Parkinson's disease, the case of a hemiplegic, or you've got somebody with a serious concussion, they can't move too fast, so they can't get adequate head speed when they're trying to do something. So this is what I was talking about in terms of the immersion process. You can have different software that and different modules that will put you in a mall. It'll put you in a grocery store. It'll have you walk up and down a stair step. You can walk out onto a building deck, and so that if you have some sort of an altitude issue, you can go ahead and habituate to work with that. If we look over here, what we're looking at is measuring gaze stabilization. But all of you have patients who don't want to be out in the middle of a room by themselves. They want to be able to hold on to a wall, hold on to a chair, hold on to a person. And so this is how you can start to enter them into the world of this immersion. The one thing I would suggest is that you consider an overhead support system. So many of our vestibular patients, balance patients, neurological patients do not have the capability of safe stabilization. And so we like to use an overhead support system that would allow them to be safe so they can't fall. In terms of optokinetics, this is really one of the best things that we've found. The main thing that the main diagnosis that I enjoyed treating was triple PD, because the patients themselves are the ones that are causing their anxiety and hence their vestibular weakness. In terms of the ability to use the software, you can see the speed at which I'm going, but I can move that speed faster and faster, or I can move out. And you cannot believe the response that the patient has when they are moving out. You're in a full field of view, and when a person is out in the middle of the forest and they're afraid they're going to fall, what we can do is we can teach them how they can manage that using their sensory system. And if we take a look at balance and postural control, this platform is there, but Virtualis also has foot plates or just small flat platforms. And so you can measure the same thing without having this type of apparatus. If we take a look at this, I want you to think about what we're trying to do. What we're doing is we're trying to fly that bird through that circle. So we have to have gaze stabilization. We have to have cervical range of motion. We have to be able to keep a stable surface on our feet and legs. And we're being inundated with different types of stimuli, this visual stimuli, so that the patient really has or can have a very complex situation. At the same time, if you're looking at using a shoulder patient, hemiparetic, or somebody that's got some sort of a weakness like a Parkinson's patient, then you can go ahead and slow this down and keep them uh, functioning correctly and safely. I will tell you that the patients themselves absolutely love this unless we push them too far too fast. And that is the problem with a young therapist who really doesn't understand the power of the software. So training is a really an important component into this, and we'll talk about that later. Occupational therapists do a tremendous amount of cognitive and motor integration. We can go to the store, we can pick up something and take it, put it into our cart. We can look for cognition, looking at different types of shapes, sizes. We can say we're going to get eggs, milk, we're going to get a box of crackers, a box of, and maybe a brown box of crackers. So we can really take a look at individualizing these neurological assessments so that the patient really has an effective and standardized treatment. The Bell test enhances different spatial awareness motions. And so again, you've got to have the ability to gaze stabilize. You've got to take a look and be able to distinguish between different programs or different factors. You can measure the speed at which they move. And so all of this is reported, and it's totally able to have it be done in your notes. One of the other things is a driving module. It's a lot of fun. You can be doing a lot of different things with it, but at the same time, you are getting really good objective data. She's got, when you're in this module with the steering wheel, you can work on shoulder and head function. You can work on back stabilization. And it basically will track the movement and responses that the patient has accurately. One of the things that I'm very happy about is that it has a standardization that every therapist can continue. You can have a different therapist treat a patient, and they're going to get exactly the same program with exactly the same accurate responses. It's ecological in the sense that it mimics real world scenarios for functional relevance. And I will tell you, one of the most fearful patients that we treat is a Parkinson's patient. And the reason is they have no control over their safety. And what this does, sort of like rock steady boxing, it allows them to be immersed into a situation with the overhead support system or in a chair that increases their participation and engagement. And they will actually have contests or competitions, I guess what I'm trying to say. If we want to measure improved outcomes, we got to do it with some sort of an evidence-based mechanism. I don't have a lot of time to talk to you about this, but I believe Virtualis and E3 Diagnostics has 22 studies, international studies, that are clinical trials. And what I just did this meta-analysis highlight. Essentially, it did 5 randomized controlled trials for peripheral vestibular disorders. There was a significant improvement in their dizziness handicap inventory scores at 0 to 3 months. And when you take a look at the different clinical differences between each of the studies, the SMD was minus 1.13, and the P score was 3/10,000ths. The VR is effective for Meniere's disease, pretty much the same thing, and also for unilateral vestibular hypofunction. And augmented reality, which is something different than virtual reality, but only in name, for peripheral vestibular disorders. They did a lot of systematic reviews, and they did in-clinic virtual reality and augmented reality versus home-based VR. The clinic-based intervention showed superior outcomes, and the home-based virtual reality had no significant advantage over traditional methods. So the necessity of having them buy this software or trying to do something with a telehealth visit didn't seem to have any effect at home. However, what happens in both of them was that their balance confidence improved and the ABC scale improved starting at the first week and up to 12 months. And you can see the difference in the p-test. The dizziness reduction really results in a faster recovery because their symptoms decreased in 4 visits versus 6 visits. And their adherence rates were off the charts, 98% over 4 to 6 weeks. And in 3 randomly controlled trials, they had 100% adherence. The thing that's probably, as we all know, is more of a problem is the side effects. So nausea, oculomotor stress, disorientation, all of these things were significantly decreased by week 4 in some of these clinical trials. If you want to take a look at how Virtualis started, it started in France, and it has had a much larger footprint in Europe than it has in the United States. So it's used in 900 plus clinics. They've treated over 1 million patients, and it's backed by 22 clinical studies globally. What this tells me is that it has strong clinical adoption and very good positive outcomes. The clinicians, and I count my clinicians in this, we have 12 physical therapists and a couple of PT assistants. They will tell you it enhances patient motivation because it's fun, it's engaging for both the therapist and the patient. We can do a lot of pain management, and we can get them to move, which is what they need to do in chronic pain patients. And when you look at the plethora of software modules that are available, and I know that Peter and Patrick can tell you how many they have. I really don't know how many they have now. You can do targeted specific treatments. So if we wanted to address some challenges, the first thing is the cost. And I know many of you will have a question about what kind of cost it is. I don't know. What we did is we contacted several of our competitors, and we talked to them about maybe going in with us on it. The cost at that time for us was $32,000. And unfortunately, none of them wanted to do that. But I think there are other methods that you can get to enhance cost sharing. Having a patient with a serious BPPV issue that is chronic, has a motion sickness issue. PPPD is a perfect example of this. They require tremendous amount of supervision. I again want you to consider an overhead support system. There are many in the United States. It's worth its weight in gold as far as I'm concerned. Virtualis, Frank was the one who came over from France to train my staff and myself when we first started this in 2017. And from that point on, I've had nothing but, and this is just my anecdotal response to, is E3 Diagnostics and Virtualis, are they good support people? And the answer is yes. I've probably in the 6 years that I was dealing with them, probably had 25 new modules. They were excellent about helping us to learn through it. I can't talk about how good their technical support is. Finally, one of the things that this has given us an opportunity to do is not to do virtual reality in the patient's home, because there isn't it's a desktop computer, so there isn't maybe there's a laptop now. There wasn't when I was able to do it, but it's the opportunity to go in and do home visits on an outpatient basis and come up with different programs in the home to create treatment situations that are in the world relative. Obviously, we want to have strategies for integrating virtual reality into clinical workflows. The first and most important, in my view, is staff training. And everybody wants to join on. I will tell you that every one of our staff has a favorite. They like to use that favorite for every single diagnosis. But there are so many that you should be able to do, 6 to 8 different programs. They need to understand the hardware in terms of how to turn it on, how to set it up with the different attachments that they have. You also have to have the software, understand how the software works. I would say it's going to take about 4 weeks for an average physical therapist to really be able to understand those two. And then the protocols are based on basically what I would suggest is your treatment protocols in your clinic. And you can modify your treatment protocols in order to enhance it with the software. You have to use this product. It is a kinesthetic learning device. And Virtualis does have, I believe, an annual meeting where you can go and get some ongoing education for different programs throughout the year. I do believe that it's important to be able to pair VR exercise, balance training, concussion management with therapeutic activities or neuromuscular re-education. It's just a commitment to document why therapeutic exercise or neuromuscular re-ed is so effective and why you're doing it. We've been audited only once by Medicare and came out 100% with our outcomes. And then you can use VR instead of using, let's say, perhaps a digital stick that works within the system. You could use TheraBand or free weights and create a much more an easy way to have the patient use it in a different manner. Finally, you can leverage the VR metrics to adjust treatment plans dynamically, and the quality of the reports are significant, and it's not spending a lot of time doing notes. It's easy to engage patients when they're having fun. And so these functional exercises to boost motivation is really a powerful tool. And when you are going out and marketing this, what you can do is give examples with video of how you get faster outcomes, better pain management, and ease of movement for patients. We like to use the VR objective data to streamline assessments and reduce session time for our administrative purposes. Most of the time, we really don't have to spend more than 5 minutes to 7 minutes, I would say, in putting in documentation. We used WebPT when I was in the clinic. As I said, I've sold mine, so I'm not involved in the clinic anymore. But now I believe they're using Prompt. And you can essentially customize VR protocols for individual needs. The benefits, in my view, are that you have data-driven care and you have streamlined assessments, which save time. The patients stay engaged. They don't get tired of it. You do have some patients who will get virtual reality sickness, and that's just a matter of we've pushed them too far. We didn't know it at the time, but now it's very easy to make sure that you prevent that. You get faster, sustainable recovery with real-time adaptation, and the benefits are significant when it comes to keeping your therapists engaged, keeping your administrative staff engaged, and the ease of billing and other factors is diminished. So I've tried to take you through a lot of information. In my view, it enhances physical therapy or occupational therapy by offering precise assessments, effective rehabilitation, and practical integration strategies. Through supported training, research is still essential to refine its application and address limitations. So I really appreciate the opportunity to talk to you, and I'd love to take some questions.
Excellent. Thank you, Mike. And we do have some questions. Some I've actually sent to Patrick directly, and then we will be providing a link where you can fill out a form, and then you get a free discovery. And again, I encourage you to do this because that's where we are in the process, working with Patrick of what is, we have to think about our room. What's our patient population? What is the kind of best arrangement for us? And I don't know if y'all caught this, but Mike mentioned about pain management, and so many of you here are in the balance world, and so that's one thing we haven't really talked about is how this is being used in pain. So Mike, I think out of my own interest is, and I can then field you some questions, is how is this used in the clinic for pain management? Is it more like on an orthopedic level?
The best way that I can answer that is to show you a picture. Is that okay?
Yeah.
So I'm going to go back and show you some slides so that, and what we'll do is we'll just use how much room do you need? This is our balance clinic right here for virtual reality. So we have an overhead support system up on top of that, that if I wanted to, I could put him in. He doesn't need it. He's really, really quite stable. But this is as much as we use it when we're doing testing and treatment. We also have a CDP, and of course, we have a huge amount of overhead support systems where in the gym, which is would be behind me, we would be able to do that. So if you think about pain, and most people who, the majority of them are medication patients. We see a tremendous amount of patients who come in halfway groggy because they're taking quite a few pills. We see patients who are reflex sympathetic dystrophy patients who, with movement or with function, are having really a difficult time going through the treatment. So what has been a value of this is the engagement. When you're immersive and you're shooting flies, let's say, with your headgear, or you're popping balloons, or you're doing something that's kind of fun, their pain doesn't seem to be as high when they do it. And what we did was we would try to measure their pain rate scale or rating when they came into therapy, and their pain scale when they left therapy. Most of the time, because with free movement, it was better. And what we found that after, and this is a long time, but we used a 12-week, 2 times a week treatment program. And what we were able to find is that about 75% of the patients were able to almost get down to a 3, or who came in at 7 to 9 out of 10, they were down to 3 to 4 out of 10 after that period of time. And the reason is strengthening, stability and strengthening. So I'd answer it that way.
Yeah, and I think, Mike, you've seen, having been in the ortho world and then mixing into the balanced vestibular world, and the growing amount of literature that connects chronic pain to chronic dizziness, and how the same applies through distraction, which is likely why you like to use it in 3PD, is we just get so many benefits when we can get people engaged on activities that we're not giving them demands for. And that's one of the things in functional neurological disorders, 3PD, is less about do this, do this, do this, and just have people carry out activities. And I think this is this is like one of the reasons I'm excited about it. I see Renew on here. She's an OT, super brilliant in the space, is asking a question about the ocular side of it. And because I am not currently a Virtualis user, Patrick, I don't know if you want to unmute yourself, but what I can say is I'm super interested in that component, especially from an assessment, looking at different ocular alignment assessments, subjective visual vertical. Danielle is a physical therapist that has used Virtualis for MDDS, and there's actually some protocols in there to easily manage some MDDS. So Patrick, I'll come back and loop it back around to you if you want to add some insights onto what's available on Pursuit, SACODs, and Virgins. Because again, we encourage you to fill out the discovery form with that link, and it is really a pretty amazing process to do a discovery with Patrick or with E3 Diagnostics, because it allows you, it's intentional. Like, what are your goals? What are the population? Are you wanting to expand? And really honing into your needs. And so as those that have followed our work know that I love the visual system. And this is really one of the big interests that I have had in this particular product. So Patrick, if you want to unmute yourself and talk a little bit about, I know we have a lot of questions, so if we can do like a quick touch base on that.
Yeah, so when you had mentioned about smooth pursuit saccades and measure and divergences, that is not what Virtualis system can do. However, within the E3 product, E3 Diagnostics product portfolio, we have that capability through other pieces of equipment. So that is something through the discovery. If somebody's interested in that, we could talk more about, but that would not be on the Virtualis system alone.
And that's how I became connected with E3, is because through using the V&G and all of those products for visual assessment, I've just been using them for years. And so to come back and reconnect with Patrick in the balance space in VR is just a newer opportunity. It does, am I accurate? I don't know if I should answer Pamela's question, but does it measure active range of motion?
Second, sorry, I was just getting back. I thought so we have a range of motion assessment. So in addition to the range of motion assessment, it's highly accurate. It's within 1/10 of 1 degree. It takes about 20 seconds to do. If a patient does have any pain, it can be indicated by clicking a button on the remote control, and then you can even move on to an activity like you're seeing in this current slide, where we can work on range of motion. We can make it go faster. We can make it go slower. We can make small head amplitude movements, very wide head amplitude movements. You can do all these different things and then go ahead and reassess through the range of motion assessment. So we do have that capability inside the Virtualis system.
And there's another question, can you use it to do joint position error and DVA?
Yes. So we do have the joint position error test in it. There's no laser that needs to be on the top of a patient's head. There's an accelerometer that's already built into the VR goggle itself, so it knows where it is in space and can measure that very quickly and very accurately. Yes, it does have dynamic visual acuity testing inside of it. In addition to that, it also has dynamic visual acuity rehab, in which you can do on the screen, or you can do it in virtual reality. So there's two options from the rehabilitation standpoint.
Excellent. Thank you so much, Patrick. And then Christine, I'm not sure if I had mentioned MDDS prior to you typing in that question. I apologize. But yes, it does have an MDDS ability in there for the movement of stripes that's based on the dye protocol. And within 360 NeuroGo, within our community, we actually have a video that many of us did a lecture together at ANPT annual conference where Carrie Hops talked about how they use it in big world, using in the military. I did it in a Vertex CDP. Danielle did it in Virtualis, and we do some case study reviews on that. So the answer to that is yes.
Yeah, it's used all the time. We even have a research study that's on MDDS using Virtualis. So really cool stuff.
And I'm going to go ahead and well, I've got a question here. I'm not going to mention the name because it is a direct message to me, and I just don't know if that's intentional. But there is a question: is there any specific vestibular rehab protocols you recommend? This is someone that works with cervicogenic dizziness, TBI, and concussion. And you know, Patrick, you and I haven't had the opportunity, and Mike would know this. I don't know if there's actual, like, I could avoid the word protocols, but are there levels? Like, is there a level 1, 2, or 3, or can you? I'll ask this: can you develop your own levels of so that you can go back and run a program more easily?
Do you want to take that, Patrick?
Yeah, so the system has a lot of things that you can do for rehabilitation. There's a lot of options, and that's part of the clinical training. That anytime anybody purchases one of our systems, we send a clinical educator who's a PT or OT that are on site, and it's either 1 full day or 2 full days of training, gives in the ins and outs. So as it relates to the patient populations that you're specifically treating, so they can show you all of that. To answer Bridget's part where she said, hey, can you create your own modules or protocols? Yes, the software allows you to modify, the virtual environments in real time. So when you're a novice user of the system, there's software that's built in, like a easy, medium, difficult. But as you become more experienced, you really want to dial it into and manipulate environments to better meet each patient's functional needs. And if you were to have a concussed patient or you have a neurological patient, you set parameters and you say, hey, I want to set this specific parameter for a level 1, and I want to dial it up a little bit more for a level 2, and then a level 3. You can save the parameters that you're in. You don't have to recreate anything. Save it, and you could save it as neuro level 1 or neuro level 2. And then the next time you go back into the software, it stores it, so you don't ever have to recreate anything. So really, the possibilities within inside the Virtualis system are limitless because of that specific capability that allows you to do that and make your own modules inside each environment.
Excellent. I've got another direct message to me, so I won't mention the name of who it's from because I never know if that's like if that was intentional or not. Sometimes I actually direct message someone and I'm in it to the group. But is, kind of why do you want to do this? And when I look at technology, I don't look at it in a way that this is what you need to make you a better clinician. I mean, you're great clinicians. This can be it depends on what your setting is. This could be a differential. Maybe, Mike mentioned like people not having this not being available elsewhere, and that can be a differential to patients that are looking for anything different and anything new because maybe they haven't had the results. Maybe that's your story. Like for my story is I've just been super interested in virtual reality because of sensory dysfunction, sensory integration dysfunction. And many of our patients are like living in fight, flight, or freeze. And they're so into the visual system and they're not tapping into somatosensory that you put when I've been playing around with virtual reality, you put a goggle on someone and sometimes they kind of freak out and because they're so visually, where am I in this room? And you're teaching them to like maybe deep breathe and focus on their feet. And I think virtual reality maybe has this amazing ability to force better use of somatosensory cues when the visual environment is not as they know it. And that's personally, like, I'm super interested, but I love reports. And so I'm interested in assessments, and patients love reports. When they can get this is where I am, and then you can have a conversation of like, oh, this shows, well, they love it. And that's one reason I've always been really so supportive of technology, is because of how objective it is. And I'm a private business owner fighting declining reimbursements. Everything kind of comes down to bottom line. And one of the things I encourage you to utilize the link that Jesse gave you for the discovery form, is there's all kinds of options. And like, we're going through that right now. What's going to work best in what can we afford? There's financing. So maybe you could get financing at $600 a month. At $600 a month, when we hear these big amounts of what something costs, that could be a 60-month lease. And there's benefits to that. There's tax write-offs for that. So those are things that you can learn. We're trying to, as a business owner, as a clinician, I think I'm wearing two hats, and I don't want to this was really about the clinical application of it all. So I encourage you to fill out that form. You get to ask those questions. When you hear numbers, don't think about paying it all at once, but over time. And if you think of $600 a month, and Mike had mentioned like engagement and decreased cancellation rates. And we've done everything we can to decrease cancellation rates. Like, okay, so now they get text reminders, and now they get this. And if we can do one other thing to decrease cancellation rates, that's going to cover our loss. So there's always, it depends if you're looking at it in that aspect. If you're not looking at it in that aspect, someone who wants to purchase it for you is looking kind of at it at that aspect. So I thought that was like super interesting.
Bridget, can I
Yeah.
make a comment?
Yeah, absolutely.
Because I think that question is one of the most important questions any of us as business owners or physical therapists need to answer for ourselves. I'm old, and so when I started out in physical therapy, one of the most amazing and fantastic modern techniques was a thing that nobody had ever used before, and it was called joint mobilization. And Stanley Paris started to develop an entire industry on the idea that you could move and stretch and manipulate joints, and somehow that would relieve pain. And what that did was it created a higher level of sophistication, and it created a much better way to quickly treat a patient. And so the answer to the question is, we have an obligation to give to our patients the very best treatment that they can have and the most efficacious. And so when you have something, and I'm going to try to blend it with the rest of the questions, but if you have something that you can work on vestibular migraines or vestibular weakness, cervicogenic dizziness, chronic cervical pain, concussion, unilateral, bilateral vestibular weakness, VOR instability, dementia, Parkinson's, concussion, stroke, visual neglect, and orthopedics as well. We owe this to all of our patients, because all of our patients have more than one problem. This gentleman that's the Parkinson's patients, frozen shoulders, spine stiffness, hip weakness, falling. He falls out of bed sometimes. And so if you can find a treatment technique that can assist in making them stop all those factors, then it's really something to worthwhile. And that's why I would buy it.
Oh, thanks, Mike. I love it. I'm gonna put you on the spot for an extension of that, because it reminded me of a question that someone asked earlier. I have seen studies that show the use of multi-sensory input and processing does result in faster improvements. But I will say, I don't know the other half of this question. I didn't know if you might. Do we know if those faster improvements, those in outcomes, what do they look like over time? And that I don't know. So the question is, are there studies to see if the gains in a program, is there any comparison of what they look like over time? And that I'm not aware. Faster outcomes while you're working with someone, yes, I've seen that research, but I've not seen it over time.
I can answer it this way because first of all, I don't have any data to tell you about that. I do have data in a program that we have a spine rehab program. And I used to go out to USC and work with a gentleman by the name of Chris Powers at USC. And there they have a very good mechanism for postural and balance control. And we had a program that we called the David Spine Rehab Program, and it was a 12-week program. And so we partnered with USC to take a look at what point did the improvements that the patient had achieved, how long did it take for them to be able to keep them permanent? And what we found is that if you do something for 6 weeks, you will have significant changes. But if you stop doing it after the 6 weeks, it will go away because the neurons are just not mature enough yet. If you do it for 10 weeks, you get some follow through. But what they found was the gold standard, just in this particular study, was it had to be longer than 12 weeks. And after 12 weeks, their strength, their pain, their range of motion was permanent.
I love that share. Thank you, Mike. And this is a true story. I did an indirect study within the clinic on, at that time, was using a neurocom system on CDP and asked people to come back at no charge. So what we did is when they met their goals, and maybe it was in 4 weeks, they could stop their home program after X amount of time and stop coming to therapy. And they had met their goals and their SOT looked great. And then we had it 6 weeks, 8 weeks, and people continued for 12 weeks. And we found very similar, we found the exact same findings, actually, to be honest, is those who continued, even though they had met their goals, is they had 3 months later, they were the best group to have maintained those benefits. Mm-hmm. And so how have I changed my therapy now? What I do now, starting as a vestibular therapist, I'm not as strict on vestibular therapy. I do a lot of overall body wellness, fitness, long-term, and keep them in therapy. And we do a lot of functional training. And I do think virtual reality is another thing that I can offer. So my recommendation is when you think about patients, get them on the books, schedule them twice a week if they can, and then think about long-term and tell them just what Mike shared. Like, we're going to get you better faster, but for you to keep these results, we need to work with you a while and have them be committed, get them on the books and long-term commitment. And that's an evolution for me. If you asked me this question 5 years ago, I would have said, I would be talking about how can we get away with the fewest visits possible, and maybe even use that as a marketing strategy. We get better, but now I'm like, no, we make it people better faster, but we want people to have these benefits. And so think as a patient, as a long-term, not all patients, but I think that's, I love that. This is an organic conversation, and my study was not anything like Mike's.
I'll just add one more thing that,
yeah.
Again, to answer the question, why should I use this? We were at first, when we were doing 12 weeks at twice a week, 24 visits, we really felt that we were going to get audited by Medicare for overutilization. But our documentation was spot on, so effective. We generated quantitative results. so that we could prove and demonstrate improvement. Again, we had, I don't know what they're called anymore, but the spot audits where they want 6 charts and, for the length of time that you're spending. And we've never had anybody, and we've never had any chart that's been denied. We've never paid any money back. But what I would also tell you is that if you're looking for a way to do a cash-based service, what we did is we used their insurance, Medicare, or their other insurances to treat them. And then they came in once a week and paid kind of like a gym. And they already knew their program. We used a PT assistant to help them go through that process, because once they stopped, they got stiff. And so in terms of their chronic pain, or in terms of their inability to do certain things, their endurance, they realized very quickly they got to keep going. And so it really enhanced our cash pay business as well.
And thanks for sharing that, Mike, because it's like a new thing that we're doing now that's really been driven by patients. They don't want to, for too long, I would be like, okay, we recommend you go find a personal trainer. And if I put that in their hands, they're not going to do it. And then they're going to digress. And so this is a great opportunity to think about. I know we're getting to the end of time. I want to go back up. And Ranu, I'm not sure if you were asking a question, but I just see and F&D. Again, for me personally, that's one of the reasons we're really interested in many of the reasons, not just assessment, but in F&D, and because we've seen such an increase in that population, is distraction works. So if I'm working with someone with a functional neurological disorder and asking them to do step 1, step 2, step 3, all those functional neurological impairments they're going to show up. There's going to be a large tremor. There's going to be sudden lower center of gravity. They're going to get, there's what you see, these impairments, but if you can distract them where they follow something, and, even Dr. John Stone, who's a leader in F&D, was one of our guest speakers at one of our conferences. And this is what he said, is we have to rethink therapy. We have to do things instead of steps, and do activities that are carrying out like functional activities is something that we know in Parkinson's. If we can have someone do something without 1 step, 2 steps, 3 steps, try to minimize that freeze, then we get better results. And this is where I think this technology is really going to be pretty awesome. All right. And Patrick, I see that you answered a question, so thank you for that. We had other rehab questions. There was one about augment. Oh yeah, that's the one were you answering the one, Patrick, about augmented therapy? Did you see that one? It says,
I did not see
okay,
that.
it said, oh, that was to me. Sorry. It says, does Virtualis have augmented reality headset option, or are you looking at that in the future?
So we do not have augmented reality. And what we've seen actually out on the market, there's nothing that is what we would call stable, meaning that you can use it effectively. There's too much lag. So the answer is no. And talking to the founder, AR is not something that at this point we are going to look to expand into. At the end of the day, we want to put a patient in a environmental condition and put them in a different world and have total control of what is happening in that virtual environment at all times. So just as an example, imagine being able to bring the grocery store, like Mike had shown in the video, into your clinic, or imagine being able to put a patient in a car with a steering wheel that they're using inside the clinic and be able to drive and move in oncoming traffic and exit off exit ramps and drive when it's raining and windshield wipers, or scrolling through a tunnel. Virtual reality allows you the ability to do that, as where AR is much more complex to be able to try to do something like that. And the way Virtualis is set up, it's not designed to treat any particular impairment. These environments are meant to treat multiple impairments. It's so robust, just to give you the scope of what we're talking about. And you've seen some videos tonight, but overall, there's 23 standardized assessments. There's 50 rehab modules and well over 150 activities that you can do inside VR, and that's excluding anything that I had already mentioned to you, where you can design your own environment and save it for particular populations that you like, that you're treating in your clinic.
All right, and you know me, I can keep on going. I do want to thank you, Patrick, for saying that about the lag. For those of you that may not be familiar with that lag, that is one of the reasons that I did not use virtual reality for so many years, because there was too much of a lag. But now that's not an issue now, because there was a worry of like a stimulus, and then how real is that? And now that's been taken care of in like the Virtualis system. That's not a concern, but it still remains, like Patrick said, a concern in augmented reality. And so I think there was something else. Darn it,
Now, a
Patrick.
good example of that, while you're thinking, Bridget, is the Wii. Somebody asked about a Wii balance board earlier, and can you use it with Virtualis? The answer was no, because that Wii balance board, and you've seen it for whoever was using it, is that lag. It's not real time movements. And with the Virtualis static force plates, we have real time movements. It's any movement you make, the force plate is moving in equal time.
Yes, and that's that. Thank you. And that reminded me of the other thought I have is, for those of you in this space working with people with visually induced dizziness and this lock in the central visual field and not processing the periphery, that's one of the things I'm super excited about in virtual reality, is having a central task with the peripheral movement. And that's what we need for visual spatial processing, is that integration between central and peripheral. So super excited to see where this goes. We do have a couple of questions. Are there handheld remotes, or it just senses upper body hand movements for stroke rehab? Also, is it mainly gross motor? That's something I can't answer. I know we're going over again. Patrick, if you want to do a quick response to that and fill out the discovery form with the link, and you can get all kinds of opportunity.
Yeah.
But yeah.
So yes, so there are handheld remotes. There are body trackers. So you can do activities, upper extremity, lower extremity, anything hip related, you can do that too. It's not just used for stroke rehab, but if we're treating for example, hemiparesis, we can do upper extremity mirror therapy. I think there was an OT or multiple OTs on this call. Upper extremity mirror therapy, you can do lower extremity mirror therapy as well. So yeah, can you use the plate to measure without turning on the headset? You do
Oh,
need
that's a
to.
good one.
Let me just think. I'm just thinking not of all the assessments for that. You can do some of it outside without the headset. Some of the assessments, a couple of the rehab modules as well, but it's designed to be fully immersed, because everyday life conditions are three-dimensional, and we don't want somebody looking at a two-dimensional TV. We want to put them in a three-dimensional environment. So you can do some of the stuff outside VR, but the power is inside virtual reality itself.
Excellent. Oh gosh, we got another one. Thanks, Bethany. Can you use some gait tests or stepping activities?
Um, currently there's nothing in the Virtualis system from a gait task perspective or stepping. So it's either on the force plate, where the force plate can move in different directions and you're controlling your balance and center of pressure. But no, nothing gait wise that we're able to measure gait. Not yet, anyway.
Can you do
It's been
activities though
mentioned.
that would require a step? Like, if can someone reach, and can you step?
Yes,
Yeah.
100%. You can step, you can reach, yeah, 100%. Yep.
Okay. So not assessment, but rehab.
Yeah.
Okay.
Mhm.
Okay. Excellent.
Yep.
All right, we want you, thank you all so much. This will be recorded. You'll have access to it for sure within 360 NeuroGo. You have a link to the discovery form. Just as a reminder, on that discovery form, you get or on that form, you get a free discovery call with some really good questions about like what your needs are. You may not even know what your needs are. So I learned about Virtualis. It had more than I realized. And then I went down a rabbit hole on the visual part. If you choose to buy as an industry partner, E3 Diagnostics has been kind enough to offer a 5% discount on your purchase. and for attending this and being a part of it. 360 NeuroGo is going to throw in a $250 gift card. So thank you all so much. We'll continue to answer additional questions. I found this super informative. Thank you, Mike. And again, thank you, Patrick. And
My pleasure.
thank you all for your time in tonight's webinar. Thanks for your questions.